Today we are going to study about the pulmonary hypertension. Pulmonary hypertension is the increased pulmonary artery pressure which is measured by right heart catheterization. The average mean artery pressure is more than 20 millimeter of Hg. Class 1 small vessel pulmonary arteriopathy. It is when the pulmonary capillary wedge pressure is less than 15 mm Hg and the vascular resistance is more than 3 Woods. And class 2 is left heart disease. Pulmonary capillary wedge pressure is more than 15 millimeter Hg. Pulmonary vascular resistance is less than 3 Woods. Here the problem is in the pulmonary veins. Pulmonary arteries, the small arteries of the pulmonary vasculature, and that is why the resistance is more, the wedge pressure is less. But wedge pressure means the back pressure exerted by the congestion. So that will be more in case of left heart failure. So if left heart disease is present, the back pressure will be more, the wedge pressure will be more, but the vascular resistance will be less. In case of lung disease, because of hypoxia, there will be pulmonary arterial constriction. The potassium gated oxygen channels will remain closed, depolarization will occur and calcium released and pulmonary vasculature will constrict and increased hypertension. Constriction of pulmonary artery will cause constriction. This is due to the hypoxia due to lung disease. The first one is also lung disease, but the lung pulmonary disease. This one is the lung disease causing hypoxia. Class 4 is chronic thromboembolic. That is, the perfusion is decreased. Perfusion is decreased. V/Q scan is done for this. And class 5 is multifactorial. All of these or some of these will be present. So class 1 is small vessel arteriopathy. That is, the pulmonary vascular resistance is going to increase. And class 2 is left heart disease. Class 3 is lung disease with hypoxia causing vasculature constriction of the vasculature and increase in resistance. Class 4 is thromboembolism. Class 5 is multifactorial. In class 1, pulmonary vascular resistance is increased, endothelin is increased, decreased NO and decreased prostacyclin. Remodeling happens and IV in situ thrombosis also can occur, obviously. Because there is arteriopathy, there can be thrombosis also. So V/Q scan, this also is deranged here. So after pulmonary arterial hypertension is happening, that is the pressure in the pulmonary artery is more than 20 millimeter Hg, we will see that the pressure in right atrium and right ventricle is increasing. The pressure in the right atrium and right ventricle is increasing. This is the back pressure. And the left ventricular size is going to decrease because the RV is going to push the septum towards the left side. Because of RVH and RV dilation, the septum is going to be pushed towards the left side, so LV size is going to decrease. If LV size decreases, cardiac output decreases, dyspnea occurs. So in case of RV dilation, RCA gets compressed, and in RCA compression, RV ischemia can also occur. RV failure and edema and syncope can occur. Mostly it is affecting the right heart. So now what will we do? How will we diagnose? Diagnosis is done by first chest X-ray, then ECG, then DLCO, because we have to understand whether it is the lung oxygenation issue or a vasculature issue. It's type 3 or 2 or 1 or 4. So in chest X-ray we are seeing there is right ventricular hypertrophy, large pulmonary artery is present in the right side because of arterial hypertension, rapid attenuation of pulmonary vessel. The blood cannot, here there is enlargement of the pulmonary artery, but there the vasculature is not completely visible because of the hypertension, mostly because of the arteriopathy. In the ECG we are seeing R wave more than S wave in V1. So it will be like this. R wave is more than S wave in V1. And if there is deep S in V1, then it is RVH. It is because of the RVH. S wave will be deep. DLCO will result in DLCO is decreased. The perfusion is decreased. The perfusion is decreased in these two. All of them. The perfusion is decreased, and hypoxia and lung disease is present in class 3 also. So due to decrease in perfusion, DLCO is decreased. The 6-minute walk, there will be more than 332 meter in case of 92% case, and less than 332 meters in 20% case. Vasoreactivity is